Cancer cannot cripple love, it cannot shatter hope, it cannot conquer the spirit. A very warm morning to you all. I, Simran, student of Banarsi Das Chandiwala Institute of Physiotherapy, welcomes you all in the webinar on the occasion of World Rose Day. World Rose Day is observed on September 22nd every year with an intention to bring a smile to faces of people suffering from cancer. It is also marked as a day to spread awareness about the disease and is for the welfare of cancer patients. The day is observed out of appreciation for Melinda Rose, a Canadian 12-year-old girl who was diagnosed with Askins tumor, which is a rare form of blood cancer. The girl's willpower and the spirit to live has inspired millions across the globe to fight the disease. After her diagnosis, doctors had given her a few weeks to live. However, she lived for 6 months. During the last phase of her life, she made each day worth living by impacting the lives of those around her in a positive manner. Her zest for life, her spirit for love, her never-ending hope and genuine caring let her achieve what many people only ever dream about. She reached out and restarted other people's hearts. The way Melinda Rose inspired other people, World Rose Day is a reminder to give back to cancer patients by spending quality time with them and bringing joy to their lives. Today, we have Dr. Renu with us to address us all on the occasion of World Rose Day. Welcome, ma'am. Dr. Renu is professor and head of the Department of Oncology Physiotherapy at KLE Academics of Higher Education and Research Center, Institute of Physiotherapy. Ma'am has done her Masters of Physiotherapy and PhD, where her title of PhD dissertation was Effect of Multimodality Chest Physiotherapy on the Rate of Recovery and Prevention of Complications in Patients with Mechanical Ventilation, a prospective study in medical and surgical intensive care units. Ma'am is a certified fitness trainer in aerobics, spinning, diet and nutrition, exercises during pregnancy, certified in orthopedic manual therapy, and instrument-assisted soft tissue mobilization, matrix therapy, and on leadership and entrepreneurship program. Ma'am is a professor at KLE Institute of Academics and Health Education, Institute of Physiotherapy. Ma'am is physiotherapy consultant and head of the Department of Oncology Physiotherapy at Dr. Prabhakar Kaur Hospital and Medical Research Center. Ma'am is also a guide to interns projects and postgraduate dissertations. She is recognized guide for PhD scholars. Ma'am is also an associate editor for Institute Journal, Indian Journal of Physical Therapy and Research. Formerly, ma'am worked as Assistant Controllers of Examination at KLE University and as a physiotherapy consultant in Department of Cardiorespiratory Physiotherapy. Ma'am is a life member of Indian Association of Physiotherapy, Associate Life Member of Indian Society of Critical Care Medicine, Life Member of Indian Society of Ergonomics, Life Member of Indian Public Health Association, Life Member of Geriatric Society of India, Member of Indian Professional Health Education. Ma'am have more than 30 publications cited in Google Scholar and PubMed. The recent ones include correlation between international classification of functioning and quality of life in head and neck cancer survivors in Indian population, role of physiotherapy in oral and mouth cancer survivors amongst non-medical professionals and e-survey, effect of myofascial release, stretching and strengthening on upper torso posture, spinal curvatures, range of motion, strength, shoulder pain and disability, and quality of life in breast cancer survivors, cigarette smoking and cessation perception in student population in India. Ma'am has many awards to her name. They include International Scientist Award as Best Women Researcher Award at Chennai, International Education Award as Top 10 Professors Award, National Award as Indian Iconic Personality Award for Literacy and Healthcare, National Award Excellence in Physiotherapy Award in Chennai, Indian Health Professional Award for Excellence in Physiotherapy, the Real Superwoman Award 2020 by in the category of doctors on 27 November 2020 by Forever Star India Award, Dr. S. Radhakrishnan Bharat Shiksha Award on 5th September 2021, New Delhi for outstanding contribution in teaching and learning, Manav Vibhuti Award for Most Promising Professor of Physiotherapy and Educational Services, Achievers of Karnataka, Vijay Karnataka and Times Group, Indian Inspirational Women Award 2021 India for superlative and exceptional achievements in the field of medical education, Sakal Belgaum Excellence Award on 7 December 2021 conferred by Sakal Newspaper Digital Kolhapur for contributions in the field of cancer awareness and screening. We are very obliged to have you here with us, ma'am. Thank you so much for joining us.
Thank you, Simran, for that wonderful and a very elaborate introduction. A very happy World Rose Day to all of you. Indeed, a very nice gesture of you celebrating the World Rose Day for cancer welfare patients. And not to miss the wonderful story of Brish Krishanji. It is indeed a learning thing, wonderful story of his simplicity, wisdom, and humanity, a great human being indeed. Could I share my screen, please?
Yes, ma'am.
Yes, can you see this, please?
Yes, ma'am.
Yeah. Good morning to one and all. In telling about oncology, physiotherapy is indeed a very big topic. However, given the time for me for 45 minutes, I will just highlight the overview of oncology physiotherapy, what all services we can do in the field of cancer, since apparently it's a new field in our country as compared to the Western counterparts. A brief historic perspective for physiotherapy, how it started. Not very important, but however, you should know how early we are or how late we are in the world of physiotherapy. So it all began in 1940s and 50s when the World War II began and a nationwide polio epidemic significantly increased the demand for physical therapists. And one should remember that polio epidemic gave rise to a lot of chest physiotherapy and the iron ventilator, or the iron lung, what we call the first ventilator that came. And then by late 1940s, the association changed its name to American Physical Therapy Association, APTA that is called, which is now referred to as today. Coming to some of the historic perspectives in India, the foundation of physiotherapy was laid in India in 1952, again with a major epidemic of poliomyelitis in Mumbai. So the pictures that you see are the ones which were there in Mumbai. The early physical therapy room, if you can just see my cursor moving, see their couches and the benches, a very remote and a very rough one as compared to the present status. In 1953, the first school and the Center for Physiotherapy was established in Mumbai as a joint collaborative project of Government of India, state government, and then the Mumbai Municipal Corporation with the technical support of WHO, just to support the polio patients. And slowly but steadily and gradually, physiotherapy formed a firm base with the formation of its own association, which we call as Indian Association of Physiotherapists, which was established in 1962. Now, when did physical therapy came into headlines, and why is it a boom today worldwide? So coming to the recent ones, I'll just name the recent ones, though it is very common in Olympics and Commonwealth Games, we have a lot of role to play. In 2006, the Wall Street Journal's careerjournal.com survey determined that physical therapists are one of the 8 best careers based on the following categories. That is in intellectual stimulation, strong job security, etc. In April 15, 2007, issue of the Parade magazine, physical therapists were found to have one of the 6 hottest jobs for college graduates in United States. A national opinion poll printed in April 17, 2007, issue of Chicago Tribune, they found that physical therapists report one of the highest job satisfaction levels in the country, second only to the clergy. And last but not the least, the US News and the World Report 2008 rankings, physical therapy in October 2010, CNN, money.com rated physical therapists as the 4th best job in America. Now, this was something that happened in 2010 and before. Now, when I interact with my friends over here, my batchmates who have come here in United States, right now I'm in United States, so I'm telling here, the friends whom I've interacted, they say now the job has become stale. We are just, it's become stagnant. We are trying to drift from different, not only to musculoskeletal or neurological, we are becoming better wellness coaches and shifting to cancer care, geriatric care, etc. So, and that is how oncology physiotherapy has gained momentum in the years. Now, in our country, it is definitely a big boom, as you can see the paper clippings of all the physiotherapy treatments that all the celebs take, and very satisfied with them. Now, just a brief note, because there are a lot of students who must have joined in this webinar, and they should know the difference between what is a physical therapist and the physical therapy assistant in the Western countries. A physical therapist is a profession that is concerned with prevention and management. We are doing that course. But what is a physical therapy assistant? The PTA, that is known as, they are assistant to the physical therapist. These physical therapists are licensed physical therapists, and physical therapist assistant is also a licensee program, but however, they cannot work independently. So they are under the direction and the supervision of a physical therapist. And they also help in instructing the patients for exercise and ADLs. Now, coming to our topic, cancer and rehabilitation. Whenever you use the term cancer, everyone is very zapped. Everyone is full of fear. Everyone is still thinking, is it really cancer or something else? You are altogether in a very confused, depressed, fearful state of mind. And this is exactly what our patients feel when they come to us in the OPD or in the IPD, not giving us the correct history, probably sometimes. They do not open up with their current status, etc. Cancer, now there are a lot of queries even amongst you or even amongst my students when I tell them about cancer. What type of cancer can we treat? Is it only the breast cancer? Is it only the bone tumors? Is it only the, the OBG cancers, etc.? You can treat any cancer that is diagnosed. So when a physical therapist come in contact with a cancer patient, you can treat any cancer. Now, what can be treated and what cannot be treated, I'll tell in my prospective slides. Now let us see what really is an oncology rehabilitation and the other related programs that are related to it and other specialty services that we can incorporate along with the oncology rehabilitation. Now, if you see the cursor that I'm moving over here, you see the oncology-based exercise programs, and these are all well-defined protocols that you get today in the literature, in the scientific literature. The radiation patients, the patients who are undergoing the radiation therapy, even they can be very well managed with physical therapy. Definitely, all of you are very well aware of the lymphedema management, which is, full blown. We always treat, and most of us think that it is only the lymphedema that we can treat in cancer and nothing else. But there is so many other things to it also. Breast cancer surgeries and the reconstructive surgeries, and as I told you earlier, all the other cancer surgeries, you name it and you can treat it. Now, what are the other things that you can treat along with what other services that you can give along with the oncology rehabilitation? Now, there are so many oral cancer patients who have TMJ disorders after a radiation therapy or a surgery. So TMJ disorders, you can have orthopedic, bone tumors, and there are athletes who have had bone tumors or probably some other problems. You can give them services. There are cancer sports also, for patients, recreational sports and competitive sports. You can train them in that specialty also. This is a very important, women's health and fitness, lot of momentum in the Western world, in Asia also, and pelvic floor exercises, which we concentrate only on OBG, but you should not forget pelvic floor exercises are very, very, very important in OBG cancers also. Now, other related programs or other related services or exercises that we can give to our patients are Pilates programs, yoga exercises. A lot of people are doing nutrition management, because remember one thing, cancer is very closely related to nutrition. Once a patient is diagnosed with cancer, radiation and chemotherapy and other treatment programs or other treatment patterns that the patient undergoes, nutrition becomes very important, because they suffer from something what we call as cancer-related cachexia, cancer-related fatigue, cancer-related pain, and so many and so forth. So nutrition forms a very important part of oncology rehabilitation. Besides that, you have vascular disorders, and you can try a treatment on dry needling. However, in my center, we have not yet started the dry needling, but you can give that. Now, a lot of queries that the physical therapists or students ask, what can we do, in cancer? Where is our job? We have, you can work in sports, you can work in ICUs, but where do we work? And I have listed so many, you can do so many, programs. If you are doing an oncology MPT, or you are very keen to do an oncology MPT. So definitely in hospitals, in outpatient clinics or offices, inpatient rehabilitation facilities, skilled nursing facilities. Some of them are Western and some of them definitely at the Indian centers. Extended care or subacute facilities, patients' home services are always there. Some of the education and research centers, and here we play a major role for awareness programs like prevention programs, schools and hospices for palliative care, industrial workplaces, again for awareness programs, anti-tobacco campaigns you can do, fitness centers, sports teams and sports training facilities for people who were athletes who want to get back to the sports again. And there are physical therapists who are traveling also. So many, opportunities you have to work as physical therapists in oncology. For people who have doubts whether there is job opportunity in oncology physiotherapy. Now, coming to a very specific, what is cancer rehabilitation? Most of us are not very well aware in our country. Let us see the x-axis and the y-axis. If you see the x-axis, it's time-bound, and the y-axis, which is activity tolerance based. Now, this is the phase where the cancer treatment, where our patients are usually rested, or in the area of the pre-diagnosis. And once there is a diagnosis done, there are a lot of barriers to which the rehabilitation either stops or doesn't progress, or somehow doesn't go to a further level. And what are the cancer treatment phase? What are the areas where we can work? It's the reduced mobility. So most of the patients, once they are into the treatment, the cancer treatment, there is a decreased mobility because of the cancer-related fatigue. There is decreased strength because of the cancer-related cachexia. And these automatically become the barrier to recovery and barrier to even physiotherapy. So what is your role here? To set small goals. Don't set big goals. Do small goals, because you never know, from 5 days of the cancer treatment, patient goes either deteriorates very badly or patient improves better. So setting of the small goals, focusing mainly on mobility. Usually in other rehabilitation patterns that you see in musculoskeletal or neurology, you're working on strength, you're working on range of motion, etc. Here in cancer, we would like the patients to move. When a patient moves, he has more confidence, he or she has more confidence in him or her. So focusing more on mobility, and once the patient is moving, then focus on strength and other things. Next is metabolism, and then there is a plateau of maintenance. Now, reaching here is a very difficult stage. Most of us, lose our patients there, or either we lose the patient because of the motivation or lack of motivation. Now, what is this cancer survival? Some of the patients do survive and they come out of the cancer treatment, and and this is what is called as a cancer survivorship continuum. If you see my cursor over here, this is the pre-rehabilitation where the diagnosis takes place. The patient undergoes the treatment, and this is the phase what we call as restorative, and this is the area where we get the reference from the oncologist, the surgical oncologist or the medical oncologist. So this is a phase where we try to restore what the patient has rather than on increasing or improving. So restoring the strength what the patient has, restoring the mobility that the patient has, restoring the lung functions that the patient has becomes very important. And this treatment can be radiotherapy, it can be surgical therapy, it can be a combination of radiation therapy, chemotherapy, surgical therapy, immunotherapy, any therapy. You are trying to restore what the patient has. Next is managing many of the other comorbidities along with the treatment. So managing chronic or intermittent recurrence, which we call as supportive rehabilitation. This also includes surveillance after the treatment and the recovery. There are so many patients who are there in your IPD, they come to your OPD and then they don't turn up, after 2 months, 3 months, you lose the track of them. So this is an area where you are trying to support the patient. You are trying to know what is the problems, where a lot of community-based rehabilitation physical therapists play a very important role. After the patient leaves the hospital or after the patient is not reporting to you, to the OPD because of XYZ reasons, like logistic can be a problem, finance can be a problem. So here is your role to reach out to them, to find out what is their problem and trying to treat them in their home settings. Next is palliative care. Palliative care is a third stage or a fourth stage where patient is almost deteriorated. There is no there's no improvement. It's an end of life care where you're just trying to treat the symptoms rather than improving anything, improving the quality of life. You're just trying to improve the quality of life along with treatment of the symptoms. So if anyone asks you, what is cancer rehabilitation? Cancer rehabilitation is pre-rehabilitation when the diagnosis takes place. It's a restorative rehabilitation, it's a supportive rehabilitation, and it's a palliative rehabilitation. So you see what a whole role of physiotherapy you can play over here. The same thing, the graph, the preparation during the diagnosis of the cancer, the battery is low, you get charged up for the pre-cancer treatment, and then the consolidation period where the rehabilitation period, the treatment is going on, and then the transformation of the physiotherapy treatment during the survivorship program. So this is what is called as oncology rehabilitation journey that you can find in the scientific literature. This is a beautiful, a theme wherein when you are new to a cancer patient, you are just getting charged along with the patient, getting prepared to treat what and where. Second is the consolidation period, the rehabilitation period really, like for example, a patient with a breast cancer surgery post-op comes to you for a mild lymphedema in her upper arm, and then you are ready to give her the lymphedema treatment. And once the lymphedema is treated, you have given the sleeves to her, etc. and patient goes home, and then that is the survivorship. Patient has survived all this and reached her home or her setting, and then you go to her place or you reach her out to check out what problems other than that she has to again support her. So this is what is pre-rehabilitation, rehabilitation, and the survivorship program. Now, though I've told that you have got a lot of area to work on, dealing with a cancer patient as a physical therapist itself is a big, challenging job. Though I have put so many, some of you will find it very interesting because you have a lot of options to work on. At the same time, it's very challenging because every day you see a change in the patient's status. Patient can deteriorate with a chemotherapy. Patient can deteriorate with a series of radiation therapy. Patient can reach an ICU just after an operation because patient's PFTs or heart status is not good, etc. It can be very innovative. Now, innovative, I tell, you can make your own protocols. I told you to set small goals. That itself is innovation. Setting small goals, trying new things. Like in our setting, we tried cupping. Cupping was a technique which was being carried out only in orthopedic conditions or in manual therapy conditions. Innovation was we tried to use cupping, the silicone cups that are there. We tried using that, and it has given us excellent results. We have tried using matrix, which was a big red flag for cancer patients at stage 1 and 2. We have tried that, and we have got excellent results clinically and with patient satisfaction. Definitely, it's not a week's job. It tests patience, both of the patient as well as a physical therapist. You have to work for minimum of 4 weeks to 8 weeks to get the result that you have as a goal. So it can be testing patients also. You can work in all aspects of PT. Like I said, you can work in musculoskeletal. For example, a patient comes to us with a head and neck cancer or with a buccal mucosa cancer. And you can work on the TMJ, that is musculoskeletal. You can work on the trapezius spasm. You can work on, breathing exercises because patients' pulmonary function tests are very low. You can work on the postural correction. So you name the aspect of the physiotherapy and you can work on that patient. So it's very interesting and very challenging. Patient psych, yes, cognition, patient mental status is very low. That itself becomes a challenge. Because if the patient's cognitive status or the mental status is not open to your treatment, then probably your treatment doesn't work. So cognitive-based rehabilitation is a very important aspect in working when you're dealing with a cancer patient. And sometimes should not forget that not all PT treatment or not all physical therapy treatment are result-oriented. You may not get, after working for 4 weeks of matrix, which is so costly in your center probably, you may not get a result of mouth opening of as near normal when you're working with a patient of TMJ dysfunction of a cancer patient. So sometimes not always result oriented, but definitely quality of life helps in their helps to improve. So these are some of the things that you should be mentally prepared when you're dealing with a cancer patient. Now, what are the characteristics of the cancer patients that can affect the achievement of the rehabilitation goals? Now, on this side, you can have a reduced life expectancy. So not a very good for us. Extensive comorbidity, because once a patient is diagnosed with a cancer, many issues get attached to it. It can be a cardiac, it can be pulmonary, it can be metastasis, XYZ, you name it, and patient can have it. Degree of pain interference, 2 days patient may not have pain, 3 days patient is in intense pain. Dynamic lesions or moving lesions, pain. They can be organic, they can be inorganic lesions. Potential for rapid progression, as I said, metastasis. Patient last month did not have any metastasis, and after 2 or 3 months, You do a PET scan and patient has progressed to metastasis. It has reached to the spine. Demands of the concurrent anti-neoplastic therapy and unique and high personalized goals of care. So these are all the characteristics of the cancer patient that can affect the achievement of the rehabilitation goals. Others are not related to PT, but however, very closely related to the patients and the caregivers. So investment in terms of anti-neoplastic therapies, all of you know that cancer therapy is not a cheap therapy. It's a costly affair. Desire to spend the remaining time with the loved ones. You want to treat the patient, but however the patient says, no, I'm not interested in your physiotherapy. Let me be happy with my family. It becomes very challenging. Levels of financial and domestic resources. There are so many patients who come to us, they can afford 3 chemotherapy, out of the 6, they can afford 3 chemotherapy sessions, and the next 3 it's left like that, and then they come with metastasis, or the disease has progressed to the next level. Vocational mandates, patient is not able to get back to the job, or patient wants a modification in the job, patient, and there are reservations to their insurance coverage, etc. It's real challenge for the patient and the caregivers. Very important, the patient has accepted, family doesn't accept, or the vice versa. So family acceptance of the terminal status, very challenging, especially if the member is, the sole breadwinner. Willingness to receive the palliative care. Not all patients are ready to receive a palliative care where they already know they are dying and they don't want to spend more money on that. Definitely a nutritional needs of the cancer patient is very, very different from apparently other I'll not call healthy, but apparently other type of patients like musculoskeletal, neurological, or even a geriatric patient. So these are all very challenging in terms of financial burden. The entire onus being, the patient or the family caregiver has to bear. So this is very important for us to keep in mind when you are dealing with a cancer patient. It's not so when you're dealing with a musculoskeletal or a cardiac patient or a neurological patient. But in cancer patient, you have to think of all this. Along with this, he is paying to your physiotherapy also. So we need to keep this in mind, the financial burden that the patient is bearing at the cost of his disease. Sorry. Okay, now what are the techniques that you can use in a clinical setup? This is very important because when you open an electrotherapy book or exercise therapy book, all seem to be red flags for treating a cancer patient, and that is the reason why most of us do not opt to treat. Now, but in our clinical setup, as you see the list over here, myofascial release technique, muscle energy technique, instrument assisted soft tissue mobilization technique. I just mentioned about the cupping, silicone cupping therapy, manual lymphatic drainage, the taping for breast cancer, or for improvement of the posture for the breast cancer patient, mobilization and manipulations. We have used all Maitland's, Carlton bones, Mulligan's, you name the mobilization technique at our center, we have used all. We've got excellent results. Neural tissue mobilization techniques for patients who had a spinal cord metastasis, is having a sciatic nerve, we have used neural tissue mobilization and given excellent results. And some of them we have already, done research and published also. So these are some of the manual therapy. If you open the book, they will have either given a, an yellow, a yellow flag or a red flag, but it's never a green flag for, treating a cancer patient. But believe me, we have used all of these techniques and we have got good results. Patient satisfaction has in terms of patient satisfaction and in terms of the physiotherapy satisfaction. Now, where do we work on? Not all are indications. So let us see where the common indications are. The red ones, that what you see on your screen, are the most commonest ones. Some of them, the black ones, are a little less. The restricted movement or range of motion. Extensively, you can work on muscle tightness, muscle imbalance, decreased facial glides, compromised connective tissue, facial mobility, soft tissue tension patterns. Now, all of this, I'll give you an example. You'll understand it better. For example, a patient has come with a TMJ dysfunction because of a buccal mucosa cancer. Now, if you just, touch your TMJ, you can see, if the TMJ is compromised or the function is compromised, definitely you'll have a mouth opening which is compromised. It will be decreased. You will have, the neck muscles which are tight. You'll have your trapezius on that side which is tight. Hence, you'll have a rounded shoulder. A simple thing, simple by pathomechanics. Now, you can do soft tissue tension patterns over here. You will try to, give an MFR and you can help that release the tension. You can give MFR to the TMJ area, which will release the tension and help in the mouth opening. You can give what do you say, the muscle imbalance improvement in terms of glides or in terms of cervical movements in the neck region to reduce the muscle tightness in the cervical area and to give a good neck movement in that area. The other are joint hypomobility in the primary as well as the accessory movements, mechanical joint pain that is provoked by movement, chronic musculoskeletal pain or the malalignment of the joint. Now, this you need to be a little careful because you never know, a cancer of, grade 2 or grade 2 and 3 can lead to a musculoskeletal pain. And without knowing the grades, if you try to treat, this type of patients, the disease may have progressed to the metastasis to the bones also. And you can induce a pathological fracture. So you have to be very careful. And that's the reason why I'm not highlighted it. You need to have a PET scan report with you when you're dealing with such patients. This is very important. If you cannot treat, please don't harm the patient. So what are the contraindications? Again, the red ones are commonly, which you should, it's a no, absolutely. So acute inflammatory conditions, severe varicose veins, open wounds, skin infections, failed or incomplete fracture healing. This is maybe a sign of metastasis also, bone metastasis, thrombophlebitis or thrombosis. Immediate after surgery, please wait for the oncologist to tell that you can treat, because you never know what his status was at the OT and in the ICUs. Neurological disease causing potential cord compressions, myelopathies, osteoporosis. Remember one thing, when the patient is undergoing chemotherapy or a radiation therapy, the bone is becoming weak. Even with 1 or 2 treatment sessions, bone is going weak. So unless and until you're not seeing the nutritional status of the patient, it is a little skeptical to treat the patient vigorously with your weight bearing exercises or aerobic exercises. So be very careful. Now, some other contraindications are marked hypermobility and severe instability. Please do not treat the patient if the patient has a marked hypermobility and severe instability. The joint needs to be stable. The joint needs to be at least, it needs to be supported before you even treat the patient with any other modality or any other treatment. Spondylolysis, spinal stenosis, and metastasis. These are 3 important no contraindications. They are absolute contraindications for your treatment, any sort of treatment. And now this is a major question everybody has. When I also started my career in oncology physiotherapy, can exercise be prescribed or just leave the patient to himself or herself? Yes, exercises definitely should be prescribed at the pre-rehab stage itself. Now, just before I go to the next, now what sort of exercises are important here? Please focus on low aerobic exercises. We are not treating here for the athletic training or anything. So low aerobic training is always a good thing. Don't forget the balance training and do not forget the proprioceptive training. Now, why I say balance training? Most of the patients on chemotherapy tend to have a little balance issues with them, and also tend to lose proprioception senses, So it is always better that you incorporate low exercise, aerobic exercise programs along with the balance exercises and proprioceptive exercises. Now again, we all have questions. What about the electrotherapeutic modalities? What all can we use? So we have used all of these, and of course, we need to be careful. TENS is a very common modality that we are using. Interferential therapy, yes. We have also used low-level laser therapy, both for healing ulcers, where bed sores for cancer patients. We have used low-level laser therapy even for TMJ dysfunctions to reduce pain. Electrical stimulation, definitely for facial palsies, etc. When a patient undergoes buccal mucosa surgery, if they have a Bell's palsy. Electroacute TENS also can be used, though at our center we have not used. If you have a modality or if you have that instrument, you can use. Matrix therapy, we have extensively used and we have got very good results. The only thing that you need to bear in mind is to be careful with the heat and cold because of the senses, because of the sensory issues that the patient may have, the one who is undergoing chemotherapy or radiation therapy. Now, some of these patients can have sensory issues. They can have decreased sensations. They can have hypoalgesia. They can have hyperalgesia. Patients who are telling, these type of complaints, be very careful when you are using heat and cold. The other therapies also have been extensively used at our center. You can also use it. It gives very good results. For example, music therapy. Now, if your patient is interested in listening to music or singing, please incorporate this at least for 10 minutes, 15 minutes. We have had a paper publication with this music therapy. It's given very good results. Movement therapy also. Now, not all patients are ready for this, but still movement in terms of ambulation, you can start slowly. And then whatever type of movements they are ready to take, please give them. It's very important for a cancer patient to be mobile as much as possible. Cognitive therapy, for example, we have used visual imagery techniques, again, given very good results. Virtual reality, very commonly used. Reiki healing, one of our students was a Reiki healer. So she used it for depression and insomnia, and we got very good results with that. Now, these are for patients who are very depressed. They do not want to move. They are not even giving good history, their history to the patient. For such patients, Reiki therapy has proved to be beneficial. Other than that, definitely art therapy, paint therapy, pet therapy, you name and it can be used. However, for all these therapies to be used, patient should be accepting it. Only then it can show results. Tai Chi is also the one that I'm moving my cursor on. Tai Chi is a very good therapy. Now you can see the lady moving very slowly. She's standing in whatever relaxed position patient can stand. So you can always make a patient stand, move, give her a target, give her or him a reach out, and slow movements are always beneficial to cancer patients. What is important? How do we go about? Where should we pay attention to? And where should we be cautious when you are dealing with a cancer patient? Detailed examination of a patient is very important. This is clinical. Patient's willingness and the state of mind. I just said, if a patient is depressed and you have not analyzed the depression, he or she will not do your exercises and it will not affect. So patient's willingness to accept physiotherapy is very important. Now, this depends on how well you build a rapport with the patient. Thirdly, pain status. Pain is an important symptom in them. It can be objectively assessed. It can be subjectively assessed, but please do not forget the pain status and noting the pain status. Feeding status. If the patient is doing on the nasogastric tubing, patient is having a liquid diet, patient is not able to have, the feeding status will tell the strength of the patient that he is going to do whatever instructions that you are going to give. What is the operative stage? There are some patients who come for second stage, second operation, third operation for the same complaint. That is to be noted. Chemotherapy sessions, how many chemotherapy sessions have been told to the patient and how many chemotherapy sessions the patient has done with. Then the radiation therapy. I have just mentioned three of them, the surgery, chemo, and radiation, because these three are the three commonly done. The skin status. Now, why this is important? Now, if you have seen a patient of cancer, radiation therapy and chemotherapy, they induce some skin changes in the patient. It can be sensory and it can be observable also. No hair growth or skin has become black, there is a discoloration, etc. There are some patients whose skin is very sensitive and there can be a wound on the skin also. So this has to be definitely analyzed. Not to miss the blood profile, very important for us are the RBCs, WBCs, and the platelets. The fatigue status, very important. You want the patient to do an aerobic exercise, the low aerobic exercise, patient is not able to even sit up. So there is no use of you making a goal of giving a patient a low aerobic exercise program. So please assess the fatigue status. Now, how do you assess? There are various scales which can be clinically used. You can use any one of them. Antiseptic precautions to be used, definitely with the COVID coming. Use Vaselines to improve the skin textures of the patient. Use masks whenever necessary. You can use electromodalities. We always used for pain. As soon as a patient is operated, first post-op day, patient referred to us, irrespective of patient complaining of pain or no, we try to give electromodality as stents. With this, patient feels that something is given to the patient and definitely patient is able to sit up in the second post-op day or the third post-op day. So that's the reason why electromodality as stents is given very commonly. Not to forget the metastasis. If you have a PET scan or the patient is carrying a PET scan, please pay attention. Please learn to read a PET scan to see the red, the hot spots there. Where was the primary tumor and where the tumor has spread to. Now, this gives us an idea to be careful when you are dealing with electromodality or when we are dealing with the exercise. Last but not the least, very important. So in which field can I get into? Whether is it only big hospitals that I can get? No, you can get into a general rehabilitation with this. There are some physical therapists who enter into well-being counseling. There is a small certificate course of 1 month, 2 months, or 3 months. You can get into well-being counseling also. Of course, a lot of physiotherapists are doing, learning something about diet and nutrition. You can be a certified cognitive therapist if you want to work in the field of cancer rehabilitation. There are patients, there are therapists who are expert in dance. Like we had a student who was very good in dance therapy. She was a Bharatanatyam dancer and she wanted to incorporate movement therapy in patients, and she did it. She did not exactly induce Bharatanatyam, but however she induced small dance step movements which made the patient happy, and you can name it as a dance movement therapy. That is why it's not a dance therapy, it's a dance movement therapy. Pilates, yes. Any form of yoga, especially breathing exercises, helps. Lymphedema therapist, this is a certified course. Exercise specialist, art therapist, people who are good in singing. Singing is very important also, not only very good, it is very important, especially for people, especially for patients who have, laryngeal cancers, who have buccal mucosa cancers, head and neck cancers, where, large part of the, or a small injury to the recurrent laryngeal nerve is injured. For these, where patient is not able to vocalize, we try to give music therapy in form of vocalizing or telling, vowels like A, E, I, O, U, and they do very well. You can join an NGO also, a lot of cancer NGOs coming up. So you have a good role to play there. And if you are very keen on spreading awareness, You can definitely do blogs and vlogs for yourself. I have 1 or 2 students who keep doing that, just spreading awareness of cancer, what you can do, what you can help, and telling people what are the risks, what are the symptoms of specific cancers. Now, these are the small glimpses of what we have done at our center, so that this gives you an idea what you can do. You also must have done it definitely, but it's just an add-on to what you are already doing. So this was a breast cancer awareness program we did to Anganwadi workers and Asha care workers. One thing to remember, see, we are all city-based. We don't like going much to the rural areas. So what best you can do is um, teach these Asha care workers, or train them to identify signs of breast cancer, teach them self-breast examination, because these are the ones who reach real to the rural areas, one-to-one for the villagers. So they are this session, what I am depicting on the photographs is we taught them. You can see we taught them by showing some photographs, performing movements, hand placements on over the head, behind the head, at the sides, so that you can do a self-breast examination, or teach the women in the village how to do a self-breast examination. Now, these were the cancer talks that we give. At least in a month, we give 1 or 2 talks in the nearby colleges, along with the community-based rehabilitation department, or we go individually. You can see in the photographs, there are a lot of girls, who are very enthusiastically listening, and they want to learn so that they can go and do it at their homes, and they can teach their mothers or aunts or neighbors, anybody. So this is very much required, in our country. Awareness, creating an awareness for all the cancers. It's not only breast cancer. It's creating an awareness for head and neck cancer, prostate cancer, GI cancers. You name the cancers, and you can do an awareness program. So that's all I had to share. Anyone wants to reach me at my email, this is my email, renu_kori@rediffmail.com. And this is my mobile number. I am always ready to help people who want to help the cancer patients, create awareness. I'm always there. We have done a good amount of research also. We have published about 35 papers. What all I have spoken about, all the treatment aspects, we are, in a process of or generating evidence, so that we can do an evidence-based practice. And yes, I think I have spoken, and I would like to take questions if participants have any questions to.
Yes, ma'am, we have few questions with us. So first question is, can you please elaborate about matrix therapy?
Do you have, just before I tell, do you have a matrix therapy? Do you have that unit at your center?
No, ma'am.
Okay. Matrix therapy is a German-based technology, which is devised by a German-based engineer. It's a Germany-based engineer. It is, it has got a probe, and it has got a frequency and a vibrator. It vibrates with a certain frequency, wherein you can place the probe on the area where you have spasm or pain, and you can set the frequency low, medium, high, wherever you want. It can be treated in the largest part of the area to the smallest part of the area. And the treatment timing ranges from about 15 minutes to half an hour. And if you have an area as large as your back, then it is about 45 minutes. And it has shown to even reduce spasticity also. So of course, we don't have spasticity patients, but definitely pain and spasm has shown excellent results. So you can just go to the YouTube and just see I'm so sorry I couldn't get the picture, but yes, definitely matrix therapy gives good results. and you can use it at your center. And it's easy to operate. It's not cumbersome at all. It's easy to operate. I think one of my students is your staff, Dr. Shruti. Shruti
Yes,
can
ma'am.
always show you. Yeah, Shruti can always show you, because she also has handled the matrix therapy, and she can tell you about it.
Sure, ma'am. Yes.
Yeah.
Ma'am, we have the next question about the Reiki healing.
Oh yeah. See, I'm not a Reiki healer, but one of my students had a certificate course in Reiki healing, and as they say, it's the energy that passes through, placement of your arms. You have your arms placed. You have to meditate, and then you keep it on your on the area where it needs to be healed, and it has shown good results. I don't know the how much scientific evidence it has, but however, we have tried to publish a paper.
Ma'am, there's a question. Electrotherapeutic modalities are contraindicated for cancer. We have been told that. Then why are we using it in cancer therapy?
There is no, for example, even TENS also, if you open the electrotherapy, basic electrotherapy book, it has told that, it is contraindicated. However, with no molecular studies done, you open the book, there are no molecular studies done which says that, cancer cells spread. It only says that it improves the circulation, right? Active inflammation, we don't use. If there is an active inflammation in the area, if it's a cancer patient, and there is a active inflammation, suppose it's a TMJ, and there is an active inflammation when we examine, then we don't use. But however, with no scientific thing, we are trying to, create our own evidence, not contradicting any other scientist. So and I'll tell you, low level laser therapy has been used by the dentists themselves. So they have shown very good results. If you open the literature, they themselves have used it, and there is a molecular based research which says it is safe. So based on that, we have used.
Ma'am, any fellowship program for oncology rehab?
Pardon?
Any fellowship program for oncology rehabilitation?
I'll tell you, this year we have passed a small value-added course at our institute, which is, it's a lymphedema management. However, we are in the process of bringing it up to the certificate level, which will be then open to everybody. Now, this value-added course is only for interns right now, which will be starting mostly in 6 or 8 months, once our interns are passing out. But there's a next step to it, that we'll be opening a fellowship in cancer rehab.
Thank you so much.
And you're always, your students would be welcome to join them there.
Thank you so much, ma'am. We were delightful to have you. Now I would invite our officiating in charge, Dr. Nidhi ma'am, to please carry forward the session.
Well, on behalf of BCIP, thank you so much, Renu ma'am. I mean, it was very nice hearing your session today. And
Thank you so much.
I'm sure all the delegates present here might have enjoyed, as well as, I mean, it might have added a feather to their cap. I mean, they might have increased the knowledge about onco rehabilitation. Of course, we cannot cover everything in 1 hour, but though it was an overview, but I think if there will be more public demand, we can have you more often, ma'am. We will keep on bothering you with some case studies, maybe in onco rehab. So I think that will be a great value addition, because sometimes what happens, everybody doesn't have that access to the patients before they enter into their internship, or maybe they enter into their professional career. So I think, but if we offer them something at this level, so it will be great. They'll be, I think the questions like contraindications, electrotherapeutic modalities will be sorted when we will talk to them, with the case studies. Probably the amount of improvement they would see with all these modalities, so it will become easier for them to relate and to understand. And of course, things coming from a person of your stature makes all the more different way of thinking about onco rehab. Thank you so much, ma'am. It was a great session, and I'm sure all the delegates have enjoyed thoroughly. and they have learned a lot of techniques at how physiotherapy is beneficial in the field of oncology. There are a lot of things which we are unaware of, but the way you mentioned them, like different manual techniques and other advanced therapies, so at least this will give them an idea that what they should learn about when they have to deal with onco patients. This will give them a
Sure.
kind of idea to progress in this field and to learn more techniques, or the techniques they are learning, how to apply them in this field also. Besides
True.
normal musculoskeletal conditions, it is important that how these patients can be managed with all such techniques. So thank you so much, ma'am. We took a lot of time of yours. We understand you were abroad and might be on your own personal assignments, but we bothered you there also.
No, no,
So,
it's my pleasure. Only one thing to remember when you see, we are too much skeptical about not treating a cancer patient. There's a lot of fear within us. We raise our eyebrows listening to cancer. So imagine the position of the patient. So the first thing is to remove our fear. The second is to remove the patient's fear, and to have a very good rapport with the oncologist. It has taken 3 years for me to have a very good teamwork with an oncologist. Otherwise, if an oncologist doesn't have a confidence in the physiotherapist, he or she will not refer. So it took 3 years for me to maintain a rapport. Now, every second patient is our patient. And that sort of a reputation you need to have. And it is not independent. We cannot work independently in this field. We need to have their consultation, their concern. A patient comes to us 2 days, 3 days in an OPD, and 4th day he'll develop a problem. We need to talk to the oncologist and get back to us. So that sort of a rapport building is very important, that type of a team building, because they don't know the modalities. And
yes.
We know the modalities. And suppose, PET scan reports, the patient may have not got it, but the oncologist has it. So we need to discuss with them before touching the patient. That's very important. And not
Very
to forget
important
the
point,
financial
ma'am.
burden.
Yes, very important point that you have touched, ma'am. That is the teamwork. This is very important aspect. Sometimes we start thinking we know our treatment best, so we don't kind of consult with them or work as a team member. So it is important that we communicate with the oncologist properly, we communicate with the patient properly, and we communicate with the family members properly.
Absolutely, absolutely. See, I'll tell you one more thing that we encountered as a challenge is, dealing with the patient's relatives. We will get a patient. The financial burden is on the caregiver who is paying. Matrix therapy itself it's a little costly affair. Okay, at our center. Now,
Yes.
to convince the patient to take is not only earning for us, but it is showing good results on the patient. Now, to convince that, we need to talk to the patient, tell the patient, patient's status, and convince the patient, and then counsel the patient, and then treat him. You just cannot blindly go and treat a patient, just because you have a treatment option for that patient. So yes, very
Exactly.
important to deal with the caregiver also, which is
Yes.
not usually done with the oncologist. They do not have time. They have line of patients waiting for them. So it's our job to at least counsel the patient. And there are patients who do not even know that they are suffering from cancer. We have IPD patients. When I go, or when I send my students for a history taking, go and take, or my interns or PGs, there are patients who do not even know that they are suffering from cancer. So all these things have to be kept in mind. They are not, as simple as, a simple history taking of another patient. No, this has to be borne in mind.
Yes, absolutely, ma'am. This is again a very important point. Patient education, family education, and we have an empathetic approach towards that patient. Very, very
Yes.
important. All these aspects. Our treatment won't be complete if we won't consider all these aspects. And one more thing I would mention here, ma'am. Like you talked about caregivers, there is statistics that caregivers are into depression, and their depression is sometimes severe than the patient's psychological status. So it becomes very important to take care of the caregivers, because they have double burden. First, the financial burden. Second, the mental burden, because they have to take care of the family member. They might be, this might be affecting their job or their personal life. So it becomes very difficult for them also to tackle certain situations. So I think we should have
I'll tell
empathetic
you
approach
one,
towards the patient, towards the
not only
family.
empathetic, sympathetic, and compassionate approach. you need to know the support network of the patients. It can be an
Yes.
employer, patient himself can be an employer, patient can be an employee, patient can be a father, mother, so many things. We have come up with a research project where one of my students did a support network concerns of a cancer patient. It's the oncologist, it's the physiotherapist, it's the speech therapist, it's the father, the mother. What are the concerns? What are the patient's concerns? Is it the mental? Is it the physical? It's an interesting topic. I think at all centers, because various geographical locations, they'll have various support concerns. It is a matter to study, and that's
Yes.
how they respond also.
Yes. So, I mean, besides our PT treatment, all these, other aspects are very important while we are managing that is why it is called rehabilitation or management. It is simply not called treatment, I suppose.
Exactly.
So, the learning for the students or the delegates, please, consider the patient as a whole. The family wise, the support system, the oncologist, the oncosurgeon. We cannot treat a patient in isolation. So, I mean,
Yes.
It was a great learning. And of course, see, when coming from ma'am, we must all understand the person who is having so much of experience in this field when is telling you that it is important to work as a team member in integration. There should be vertical and horizontal, both kind of integrations. So we should always keep these things in mind when she has already faced these situations, so can we. So I think we should take a learning from here and then work accordingly.
Yeah, one very interesting thing I would like to tell. Initially, it was very difficult, just like all the consultants, they do not easily, have a, confidence on us, probably. But somehow we try to build a rapport. And I think every 6 months now at our center, we have a tumor board meet. Okay. Where all this, I mean, in your center also, you can do something like this. It's very interesting that the radiation oncologists, the surgeons, the chemo physicians, and even the fellowship surgeons, the dentists, the physiotherapists, and the staff, my postgraduates, their postgraduates, we all sit together around the board and we discuss a case or we discuss our problems that, we are falling short of the references, or this patient is not going, what sort of a patient do we need for rehab? So the exchange of ideas improves your IPD, OPD status also, and exchange of ideas also, because they are absolutely not aware of what treatments are available. See, they only know physiotherapists are exercise. Now, what sort of exercise? My oncologist did not know there was matrix therapy. My oncologist absolutely did not know that matrix therapy could be given. Or, a mouth opening, they only know that the mouth exerciser is there. They do not know what is manual, myofascial release. So all these things, and now it's very interesting that the oncologist himself comes for his own treatment of trapezius now. No, these are very interesting facts, and it opens up your avenues as well.
Yes. I would mention just one thing here. These all experiences are not mentioned in any book. So,
No.
this comes from the learning of such people, so we must take advantage of the experience also. They have learned over the period of time, and now these people are telling us, so let us take advantage of their experience and imbibe all these things. These are very important aspects, which no book can teach. Only gray hair can teach.
Yes. True. I am getting a lot of messages of participants. Thank you so much for your appreciation for my presentation. Yes, I would like to be connected with you people, and any help from my side, any knowledge exchange from my side. Let us have a case study exchange, because that is very interesting, where you can have a head and neck cancer patient coming up at stage 2 or stage 3, a post-op or a radiation, and then let us see what we can give as a treatment protocol, and let us see how the patient improves. That can be an excellent learning.
Yes, of course. That is why I always tell, we here at BCIP always tell our students case presentations, case discussions are very, very important. You learn a lot of things while you discuss the case with different people, all the team members especially. So,
Absolutely.
that exchange of knowledge gives you a lot of learning. and it becomes really important, and it helps in improving the condition of the patient in the longer run. So thank you
Yes.
so much, ma'am. It
I
was a
just one
great
sec.
learning session.
I can see a hand up from
Yes.
Rita, ma'am.
Rita
Yes, ma'am.
Mahesh.
Yes.
Yes.
Yes,
Yes.
ma'am.
yes, ma'am.
Hi, ma'am.
Hi.
It's really heartening. Your talk was just fantastic, and it's heartening to know that we can use electrotherapy. I
Yes.
am a practitioner in Delhi, and I have been doing a lot of shoulder mobilization cases post breast surgeries, and I get very good results with instrument-assisted soft tissue mobilization and other techniques of mobilizing the shoulder. But it's really nice if we can add IFT, because pain is an issue. So it's good to know that you're successfully using a lot of electrotherapy. So that has been a very good learning today. And overall, the lecture
I
was.
would like to thank you, ma'am. I would like to ask what instrument assisted mobilization you use?
I am using a blade. Would you like to see it? I can just show it to you. I'm right here.
Yeah, yeah.
Yeah. So I don't know if you can see it. That's
Okay.
the
Okay.
blade.
Yeah, I'm a little skeptical about using this. Now, why? I'll tell you. One, because it's a little hard on the skin of cancer treatment patients.
Yes.
Because if you have seen a radiation patient where skin is already very papery and very tender. So
Yes.
in them, you can use jade stones. I have not mentioned jade stones. If you're trained using a jade stone, jade stone also comes in the same shape and it is a little blunt on that side. So if you can use that, that will also give you excellent results. And I would suggest you using cupping also, silicone cups, dry cupping techniques that we call. You can use, just apply a gel or a Vaseline over the skin and, just move the silicone gel on the, the fascia, how the fascia is. So that gives excellent results. It really soothes. Yes, it gives excellent result. And patient would, patient himself asks, "Mujhe wo diya tha aapne, abhi kyun nahi de rahe ho?" So this is very good for TMJ, for breast, as well as for even lower limbs also.
Right. Thank you, ma'am. Thank
Yeah,
you.
thank you. Anybody has any questions? I would be more than happy to answer them.
More than questions, ma'am, it was really good.
Regarding
The overall session was more than
the role of
intensive, extensive. I'm into cardiac
Yeah.
rehabilitation, but listening to cancer rehabilitation, the way you presented was more than answering. So nice.
Thank you so much.
Thanks from
Thank
all
you.
of
Thank
us.
you. Thank you so much. I have worked for 10 years in cardiac rehab, and then cancer rehab interested me. So,
I
because I
think
did my
this is
PhD.
how base of cardiac rehab also works, because cancer requires damn every utilization of the knowledge of physiotherapy at whatever ends you have.
Yes. The only problem is you cannot extensively give an exercise session to a cancer patient as you give to a
Agreed.
cardiac patient because of the cancer related fatigue and other things. But however, yes, the base like pulmonary functions and the cardiac functions, you have to keep in mind when you're treating them.
Ma'am, just one thing, the way we use
Yes.
VO2 max and RMR calculations and prescribing exercises in cardiac rehab, have they been used in cancer work also, or prescription of
No,
exercise, or again it is
no,
for
no.
only clinical
No,
and subjective?
I use subjective. If
Okay,
patient
most
tells
of
I'm
the
getting
times it is
fatigue,
like that.
yes, I don't. There's a question for me. Can we use cupping for lymphatic drainage? Yes. Yes, you can use cupping. We have used that also. Dry cupping for lymphatic drainage. You get different sizes for, cups. So yes, you can use. Okay. I think no questions.
Yeah, no questions.
Thank you for the invitation. It was beautiful interacting with you. Speaking of cancer, I would always love to interact, especially for case studies. It's more useful. Patient satisfaction, your satisfaction, and the patient relative satisfaction. So all three together. So thank you again. I should thank Shruti for inviting me. You know, whenever my students from any corner of the world calls me, I can never say no. So thank you so much. Thank
No,
you
ma'am,
so
the
much for
pleasure
that
was all
invitation.
ours, and we hope to see you someday offline taking a lecture, maybe.
Oh, no problem. Yes, definitely. That would be, for me, I would love to come to Delhi that time. It's long that I have not come.
So I
So
mean,
yes.
yes. So it will be great to host you in Delhi then soon.
Yes, sure, sure, sure. Thank you so much.
Thank you.
I would also like to invite you people to please come and see one of our beautiful centers. We have a state-of-art clinical setup. Please come down. We have a water hydrotherapy pool, and of course we have 11 specialities, and each specialty is it's special in itself. So whenever you are down, Shruti can always give you a reference, and please come down. I'll be your host for that. Thank you so much.
Thank you so much, ma'am. Thank you.
Thank you. Thank you.
Thank you.
We have shared the feedback form in the chat box. Kindly fill them, please.
Well, it's done. Can we leave now? I filled the form. Anything else to be done?
If you have any suggestions, then please let us know.
Yeah, please do inform when she's coming to Delhi. I'm from Delhi, so would like to have a live chat on.
Sure, ma'am, sure.
You guys are organizing again with her, some live session with her?
Ma'am, we'll see to it. Not surely confirmed right now. Whenever we get any confirmation, we'll let you know.
Thank you so much. Thank you so much. I can leave now, no?
Please stay in the WhatsApp group for further informations.
Sure, sure, sure. Thank you so much. Thanks for organizing it for all. That's really nice.
The certificates will be issued on the basis of feedback form. So please make sure that you fill the feedback form correctly.